And you can feel perfectly fine and have very high blood pressure. That's why it's called the silent killer.
The silent killer.
Yeah.
Hello. Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is my friend, Dr. Kellar Winkelmeyer. Welcome to the show, Kellar.
Thanks, Gil. Always appreciate getting to talk about interesting stuff.
Yeah, and what you do, Kellar, is very, very interesting. Kellar, you are a nephrologist, which means you're a doctor that specializes in the kidney, but the kidney is responsible in part for our blood pressure.
That's right. It's also an organ that you can live without if you have to, but better to have it.
Better to have it. So the kidney is very, very complicated. Requires a lot of training to become a nephrologist. So did you? Where did you go to medical school?
I went here in Missouri.
In Missouri, and then did you do a residency in internal medicine?
I did.
That's generally about 3 years. Where did you do that?
I did that here as well.
And then you did did you do a fellowship or subspecialty training after that?
I went up to Mayo Clinic in Rochester.
Mayo Clinic.
2 years.
That's very competitive. You must have been quite quite an excellent resident to get a fellowship in nephrology at Mayo.
I don't know, but it was an amazing place to be. It was an amazing place to see how they do medicine up there. And they treat their people very well. So I can't say enough about that experience.
Yeah, I could tell you we're in the Midwest. We're about a day south of Rochester, Minnesota, a long drive.
400 miles.
400 miles. And I know if we have a surgical specimen we're not sure about or we want a second opinion, goes to Mayo.
Yeah.
Mayo's got a great reputation. And wow, so you did a fellowship in nephrology. And did anything happen in your childhood or early in your life that made you say, hey, I want to be a doctor?
I didn't decide I wanted to be a doctor until I was 21.
So you were already in college?
Oh, yeah. I was a psych major. I was getting a degree in psychology, and I was interested in taking care of people with mental illness. And then I did an externship in an outpatient psychiatric facility, and I just completely hated it every minute of it.
You couldn't do that every day. You knew that wasn't for you.
Well, yeah. But I also, at the same time, was doing assistant rat brain surgery with some of the postdocs. And I found out that I had a knack for rat brain surgery. Although, they never had insurance. Not again. But, and my advisor said, well, what, if you hate being a psychologist, why don't you be an MD instead, be a neurosurgeon or a neurologist or something like that. So I thought, really? And I ended up taking all the pre-med courses when I was a bit older, which I think made all the difference in the world as far as making the grades and getting into med school.
So you got into med school, and when did your interest go from neuro or potentially surgery into nephro or kidneys?
I think one of the things that I didn't like about mental health is it was so nebulous as far as measuring things. I mean, you can ask somebody if they've, killed anyone lately or, how they're feeling, but it was all kinds of nebulous. I think I have enough OCD in my personality that I needed things I could measure. But I also wanted relationships with people. And I found, generally in internal medicine, helping people deal with diseases was very interesting to me, and it fit that need that I had for relating to people and helping them or feeling like I could help them. And nephrology took care of the sickest patients, and they had really interesting things to measure. The electrolytes and the labs and the chemistries and the blood pressure and KT over V and all the stuff that we do.
Right.
So that appealed to me as well. So that was how I and also there was a inspiring man named Dr. Carl Nolf at Mizzou at that time, and he inspired me. He would give these great lectures about nephrology. I love when he talked about the development of the concentrating mechanism, the kidney, and related it to the invention of beer. That was a brilliant.
That's it. That's those special teachers, Kellar, those special mentors and people that inspire us are just so important.
Yeah, I think so. Well, hopefully would pay it back to someone else.
Yeah, and then we pay it forward. Exactly. That's the circle of life, and how medicine has always worked and probably will always work. So, high blood pressure is something you deal with all the time.
It's one of my favorite things to deal with because it's probably as close to preventive medicine as I get. Most of nephrology is disease management. We see people with serious, big-time illnesses.
After the kidney is failing.
They're failing or involved in a multi-organ problem. Whereas if I see somebody with hypertension and I control it and teach them how to control it, we've really prevented a lot of that stuff.
All the way for decades for the rest of their life. So hypertension means pulled, which they're talking about the blood vessels, particularly the arteries are under tension. There's hypertension, and that's what is the medical term for high blood pressure.
That's right, high blood pressure. And I have a sort of an oversimplified way of describing it to people, but there's basically three things that determine your high blood pressure, or your blood pressure in general. The heart pumping, the vascular tone, the blood vessels squeezing, and how much salt is in the system.
And how much volume is in there.
And those are the three things that we play around with when we're trying to use medications to treat high blood pressure.
Those the foundational concepts you use. So let's talk about that. Our heart isn't a constant pump. Like you turn on the spigot, the water flows smoothly. Right. It comes in pulses.
Yeah, that's right.
So when the pulse comes out of the heart, if it were to hit a rigid pipe, it wouldn't work. It would go straight through. It just wouldn't be possible. So you need some elasticity when the heart pumps into the aorta and it goes down the line. It has to be able to stretch a little bit and then shrink back and stretch. And it takes this pulsing and it slows it down eventually to a kind of a constant stream. But you've got this pulse and you've got the height of the pulse and the low of the pulse. And those are the two numbers that we see in a blood pressure reading, aren't they?
Systolic and diastolic.
Systolic and diastolic. And that's related to mercury. I said, why is mercury? Because it's real easy to make a mercury tube and connect it to a blood pressure. And it's the same everywhere.
I actually have an old mercury sphygmomanometer, which is a blood pressure measuring cuff, in my office, and someone told me if I dropped it and broke it, they'd have to evacuate the building.
As we were kids, we used to play with it, right?
Yeah.
Break the thing, play with the mercury.
Not anymore.
Yeah, it's a hazmat. Yeah.
Getting back to the heart, we kind of want to make our muscles big, but we don't want our heart muscle to be big.
Why is that?
A bad thing. Well, it doesn't use oxygen efficiently. It actually, if it gets really big, it doesn't pump blood efficiently.
So bigger is not better.
Bigger is not better for the heart muscle, and that's one of the consequences of blood pressure. In fact, let me just go over the general bad things that happen to people with uncontrolled hypertension.
I wish you would, and I want to mention this statistic. I was horrified or surprised that apparently up to half of our population has high blood pressure.
Yeah, and if you
oh my goodness, half, that is enormous.
Over 65, it's 2/3.
After age 65, 2/3 of us have high blood pressure.
So there's good job security if you're a hypertension guy.
Oh my goodness, that's up there with HVAC. Everybody needs it.
Yeah. At any rate, as far as what happens to people, bad things that happen to people with high blood pressure that's not treated.
All right, give me the bad news.
Well, basically, it damages blood vessels, and there's three categories of problems. Number one, kidney problems. Your kidneys are made up of little balls called glomeruli, small blood vessels, and the hypertension can damage those, and you can end up with kidney failure.
Oof.
Next thing is stroke. You can have buildup of plaque in your arteries going to your brain, or you can have enough hypertension that you can actually have a bleed in your brain.
You actually burst a vessel. Yeah. Bad place to have a bleed.
And then heart disease, heart attacks, and congestive heart failure.
Because of damage to the arteries and the of that feed the heart from this high blood pressure.
Heart failure is caused by weakening of the muscle of the heart, which can be from heart attacks, where you lose the arterial support to the heart, or just the effect of blood pressure on the heart over the years. So, at any rate, those are all things we try to mitigate, and hypertension is one of the most powerful things you can manipulate to reduce your risk of those things.
This is so important. I'm so glad we're talking about this subject. So what is the usual cause of high blood pressure if it's so prevalent?
Well, you got me there. We call it essential hypertension. And essential just means, we don't really know why people have we have ideas. It has to do probably with our lifestyle and what we eat and our activity or lack thereof.
And genetics at all? Does it run in families?
It does.
Essential hypertension?
And there are different flavors of hypertension. People sometimes can be very salt sensitive. In other words, their blood pressure goes up dramatically with sodium.
I want to get into that. That's a very, very important.
So much. Yeah.
That's a very important topic. So most of the blood pressure problems are essential or primary, and people just seem to develop it. We don't always know the reason. And that's the majority of high blood pressure?
The majority. But we do know that if we control the high blood pressure, we prevent many bad things from happening.
Down the line.
Now, there are some secondary causes. I can just go through briefly, but you see them generally, rarely. Having a blockage in one or both of your arteries to your kidney can cause high blood pressure because, as you mentioned, the kidney is the sort of mastermind behind most of the factors of blood pressure: vascular tone and salt and water, everything but the cardiac output. And if the kidney thinks your blood pressure is low because the arterial supply is reduced, then it puts out hormones to drive your pressure up. It's called renovascular hypertension. There's also hormones that come from your adrenal gland.
Now, that's the gland that sits above the renal, and renal's part of the name, adrenal. And you've got to know about those too, don't you?
But they're completely different than the kidney, but they're very important in blood pressure control.
And they're next to each other probably because they have to communicate.
I don't know why they're next to each other, but perhaps. But aldosterone is a hormone that causes us to retain salt and can regulate blood pressure. And sometimes we can get a benign growth in our adrenal gland that puts out too much aldosterone. And that's another secondary cause of hypertension. One of the commonest treatable secondary causes of hypertension is sleep apnea. It seems like everybody in the world has sleep apnea.
Sleep apnea. How does that affect your blood pressure, Kellar?
Well, it puts a massive stress on your body because you don't sleep very well. You have these little alert. You don't have the nice sort of deep sustaining cycles of REM sleep. You have these little bursts of alertness all the time. That's associated with obesity, which is a popular condition in our country.
Also over half of us. Wow, very, very common. So there's the slow, chronic high blood pressure, and then there's these kind of sudden, or all of a sudden your blood pressure was fine, and then it's gone up acutely, and that's the sign of one of these secondary problems,
it can
perhaps.
Be. There's also a rarer kind of problem from the adrenal gland where you have a tumor that puts out adrenaline or epinephrine, norepinephrine, called a pheochromocytoma. Very
rare, but very serious when they happen.
My first day in the hypertension clinic at the Mayo Clinic, we saw 6.
Whoa!
That's just one of the benefits
that's more than some people see in a career.
That's about how many I've seen in 40 years here.
But as a fellow, they all get funneled in.
They get shipped from all over the world.
They get shipped,
But that's just an example of how cool it is up there.
And what kind of training you had. Oh, my goodness. So let's get to those in a second. So let's go back to this essential hypertension. How early in life might that be seen?
Even teenage years, 20s, 30s.
So on a checkup, getting the blood pressure on a young teenager is still important. We know where's their baseline.
I think it was Mark Twain that said, if somebody's only tool is a hammer, every problem looks like a nail.
Looks like a nail.
But I do think that high blood pressure is, apart from smoking, one of the biggest modifiable risk factors for cardiovascular disease. And so it is, I don't want to say that we should be checking little babies' blood pressure,
Right. But a high school physical, getting the blood pressure, very important. Find out where you're starting.
Teens and 20s and stuff like that.
Because essential can show up that early.
And you can feel perfectly fine and have very high blood pressure. That's why it's called the silent killer.
The silent killer. Yeah. You feel fine. And when do you start getting some idea or some signs or some inkling that, gee, there's something wrong here? What are the things that might alert someone that they've got really high blood pressure?
Like I said, sometimes you feel fine, and just you get your blood pressure checked, and the dentist won't work on your teeth, or someone tips you off to it. The other thing is, when you have a heart attack or a stroke, or you get people think that hypertension causes headaches, and it's really kind of unusual for that to happen.
It's got to be really high to get that, right?
Most often people I see with that complaint have migraines, and they have a terrible headache, and someone checks their blood pressure, and, oh, your blood pressure is causing your headache. But it's actually the headache is exacerbating the blood
pain,
pressure.
yeah, giving them high blood pressure.
Fortunately, there are some blood pressure medicines that discourage migraines, so that's another example of having a secondary benefit from your blood pressure medicine.
I do see
it tailored.
Patients occasionally on propranolol or some kind of what's called a beta blocker.
Exactly.
It helps both. So
you're not just a dumb GYN. You've
I'm
been around.
I'm actually a reproductive endocrinologist. Imagine that. So
just teasing you.
I like getting teased. Oh yeah, we get teased. There is a condition in my world, in the world of infertility, called unexplained infertility. And some clinics have rates, 15, 20, 25% of their patients have unexplained infertility. Well, I have a problem with unexplained. And I think unexplained is the refuge for the stupid and the lazy. Yeah. And if you look hard enough, you really can find the reason. And in my world, I think unexplained is maybe about 2%, 3%. It's just that rare person you throw up your hands, but you've really done a good job, a thorough job looking for the problem.
Due diligence.
So, due diligence and caring, and putting what I call the intellectual horsepower into a problem. So if you had to say these people with primary or essential hypertension, if you had to really delve into what is the true cause, what would your ideas be about causes, rather than saying, hey, 90% unexplained, we don't know why? Give me some thoughts on why you think there's got to be a why there somewhere.
Well, I think you are what you eat and what you do. Certainly lifestyle changes, including the Mediterranean diet, not being obese, moderation in sodium intake, exercise. The older I get and the older my patients get, which sort of happens together, at least not in your business, but in my business.
A little bit.
The more I realize that exercise may be the closest thing to the fountain of youth that I know.
Yeah, it's getting a lot of attention right now. Grip strength, for example,
Sure.
being associated very tightly, very closely with longevity and wellness.
Yeah, that's not to say that there isn't, a bell-shaped curve. Excessive exercise, like excessive anything, can be harmful.
Sure, marathon running. I mean, you're probably old enough to remember Jim Fixx. Jim Fixx was this marathon guru. He wrote all these books, and he died of a heart attack when he was running.
Well, that's because he thought that it would prevent him from ever having a heart attack, and he had other risk factors that weren't addressed.
Right. It's not a cure-all for anything. So exercise good. Now, is there any data to suggest that aerobic exercise is better for blood pressure, or high intensity, or weightlifting, or just walking, or is it all good for blood pressure, Kellar? If we're just talking about, so we can separate just the exercise part. Is there any data to suggest that one is better than the other? I'm not aware of any, but you know better than I.
Well, yeah, I don't keep up with the exercise physiology data per se, but I would imagine cardio would be what you're looking for cardiovascular benefits.
Some kind of activity.
Yeah. Now, talking about diet, exercise, and lifestyle changes doesn't mean that that's going to take care of everybody's hypertension, particularly the people that get sent to me. I had a lady whose chiropractor put her on vitamins and said that she needed natural medicine for her high blood pressure.
Right.
And so she stopped all the medicine that I had her on, which was 4 drugs at the time.
Oh, boy.
And she had a stroke. And I saw her in the hospital, and I said, natural for you is
death.
Is death, yeah.
Yeah,
and
yeah.
There's lots of toxic natural things. So some people just need medicine. And fortunately, and this is really one of the great things about hypertension, we have a lot of blood pressure medicines, and they're not very expensive mostly.
And a lot of them are
like
safe,
diabetes.
Too. Yeah.
And we know a lot about most of them as well.
And I want to get a little more granular about that in a second. So we talk about exercise. Now let's talk about diet. Now I've got a bunch of people that we've already interviewed, and I have a whole bunch more in the pipeline that we're going to be talking to. Nothing is more controversial than diet. And we've gotten on, so I would call some bad leads or some dead ends or some tangents over the past 40, 50 years that have been very unproductive.
Yeah, the low-fat diet, for
The
instance.
low-fat diet, just ridiculous, because what do people substitute fat with? Carbs.
Yeah.
And and so I can say we all agree that a more whole diet, whole foods, less product, less
better fats,
better fat, less processed foods, etc. Seems like everybody's agreeing on that, even in the conservative institutions.
Also, just less food.
There's that too. There's that too. But when you eat meat and fat and protein, you tend to eat less, so it tends to help each other. So we can all agree that less processed foods, probably fewer carbs and grains, and keeping our
be aware of how much sodium. One of the things
okay, let's go to sodium because this is so controversial, Kellar. Talk to me about sodium, which is salt.
Yeah, salt. Different people respond in different ways to sodium intake, but by and large, it's one of the major components of blood pressure. And when I ask someone to reduce their dietary salt, and they stop using the salt shaker, but they don't change anything else, they reduce their sodium intake by about 15%.
So it's that sneaky salt
in the food already.
I didn't know that. Only 15% is added.
Yeah. Now, I had a patient who switched from salt to kosher salt. She said, it was just as good. I said, that's just salt tasty. Blessed by a rabbi. She said, how about sea salt? I said, that's just salt. But from the sea,
Yeah,
it's got the word salt.
And all salt is originally wherever they mine this salt, whether it's in the Himalayas or whatnot, it was once a seabed. I mean, that's where it's good. And a little pink in there might have some trace minerals, but it's
it's important that you get some salt, but we tend to get a lot of salt in it, particularly if you have comorbidities such as heart disease and stuff. It can be a big deal. Now, as
a blanket statement, I can see. There's public health doctors and masters of public health, and they make a blanket statement, like we should put folic acid in the grains and you'll prevent so and so many cases of spina bifida. Yeah, iodine and fluoride in the water for cavities, and they look at these general terms, but I hate when they take it down to the individual. Now, how can you tell if an individual is salt sensitive? Because clearly some people salt doesn't seem to make any difference or much difference.
It's true. If they have edema, if their ankles swell up at the end of the day.
What does that mean?
That means they retain salt.
So you can get an idea by examining them carefully if they are a salt sensitive person. Is that what I'm hearing?
Yeah. Another thing is if they complain that they have to get up and urinate at night a lot. Because what happens is during the day, they retain fluid, and it goes down to the dependent part of their bodies, in the legs and the ankle.
Gets into the tissues.
You lie down.
And
so then you wake up and your bladder's full. And so paradoxically, either reducing salt or taking a diuretic in the morning can make you not have to get up and urinate as much at night.
At night. Interesting. So just so I understand this, does this mean the majority of people are salt sensitive, and in the majority of people, if you keep your salt and sodium down, it'll help their blood pressure? Is that a general rule?
Yeah.
Is it enough to recommend to everybody, or should they see someone like you before they salt restrict?
Well, there aren't enough people like me to see everybody with high blood pressure.
Yeah, isn't that the truth?
But they need to see somebody and have a rational approach to their blood pressure. More people are salt sensitive than aren't, but it isn't a massive majority. There are people who do not appear to be salt sensitive. And part of it is the response to different medications too. Now, usually people that I see aren't hypertension 101. They're people who've their primary doctor has had difficulty controlling their blood pressure.
So you're getting the tough nuts to crack.
Yeah. Now, the best compliment I ever got was a family practice doctor told me that when she sends me patients, they came back with better blood pressure on less medicine than when she sent them, which I felt very good about.
That's a hell of a compliment. That means you're doing something right.
Yeah.
So keep your weight down. And another controversial topic, eat, exercise. In general, let's say we keep the sodium down. Somebody has high blood pressure and they come to their internal medicine doctor. So let's say the first cut from a generally a smart doctor, but has to know a lot of things. In internal medicine, or you're seeing a family practitioner.
Yeah.
You're seeing everything. You got a sprained ankle.
We're talking about half of everybody So, I mean.
Yeah. So what is a competent, well-trained generalist primary care doctor going to consider, and then how are they going to treat somebody? Because most of us will be treated by our family or primary care doctors.
Well, first you measure the blood pressure, and if it's over 120 over 80, then it's pre-hypertension. If it's over 135 over 85, then you consider it hypertension.
Okay.
And
now, which number? Now, this always confused me, Kellar. Please help me here.
And there's arguments about those numbers.
Yeah, I know. It's so nebulous because, I had to do a lot of obstetrics in my training. We deliver women, and 15% of them will get severe blood pressure problems. And they always said if blood pressure is above 140 over 90, that's high blood pressure. Consider something called preeclampsia. And they never explained, at least to my satisfaction, well, is it the 140? Is it the 90? Is it the mean arterial pressure? Is if one is up? And then the cardiologist and the nephrologist start saying, well, if the systolic this, but they start dividing it. It gets really complicated.
It's both. I mean, when I was a young whippersnapper in med school and stuff, they talked about the diastolic predominantly, but the diastolic being the lower number.
The lower number.
That being most important, but they're both important. Systolic perhaps a little more associated with stroke than other cardiovascular outcomes, but they're both important. And if you have regular, not severe hypertension, try some lifestyle stuff. Tell them to lose weight. Tell them to exercise. Tell them to reduce their dietary sodium. But if it's very high, then you generally would put them on medication to begin with.
All right, so your primary care doctor, they haven't gotten to the nephrologist because hopefully they're the easier, simpler, less complicated blood pressure. And they're doing all these other things.
Yeah.
Where's your primary care doctor going to start? You mentioned there's different types of medicines. And
as far as medicine treatments?
Yeah, well, where do you start?
Well, there's three classes of medicines that are usually sort of hypertension 101.
Okay, what are those, please?
One is a diuretic, and it's called a thiazide diuretic.
Mm-hmm.
Now, hydrochlorothiazide is the traditional thiazide diuretic, although I rarely use it because there are two other options in that family that work better. One's called chlorthalidone. The other one's called indapamide.
How come I don't see that? I see patients on hydrochlorothiazide, HCTZ, all the time.
I mean, it's okay. There are better options that are equally cheap.
They're equally cheap, so this is not some super expensive new drug.
Yeah, well, indapamide is the newest, but it's still not expensive. The difference is that chlorthalidone and indapamide have long half-lives, and hydrochlorothiazide has a relatively short half-life.
Sure, and half-life is how long it stays in your body, and a short half-life, you got to take it more often.
Yeah.
It's a pain in the ass.
So you get about 5 millimeters of mercury more with indapamide, for instance, than hydrochlorothiazide.
And it's not expensive.
No, it's cheap.
Okay.
Okay, so a diuretic. The next category of medicines you might start with is an angiotensin-converting enzyme inhibitor, called an ACE.
ACE inhibitors, and that works.
Or an angiotensin receptor blocker.
Receptor blocker, the ARBs. Yeah, so the ARBs are more recent, but still pretty old now, right? Well established.
And cheap and very effective.
So the ACE inhibitors.
ACEs and ARBs.
Okay. And is there any reason why you would start on an ACE or an ARB?
You want to tailor it specifically to the patient. Number one, if they might be having babies, you don't want to do either of those drugs.
Not good for pregnancy.
Right. So even if they're at reproductive age and they're maybe not, don't go there with those drugs.
Yeah, avoid that risk if you can.
That's the only drug really in that category that is a no-no for pregnancies.
Right.
Just saying. But if somebody, for instance, has some heart problems, angiotensin receptor blockers and ACE inhibitors are very beneficial for the heart. If someone has some chronic kidney disease and proteinuria.
That's protein in the urine. Yeah. These glomeruli you were telling us about are supposed to let the salty solutions through but keep the protein in the blood. It's like a little filter, and if that's starting to break down, then you lose protein, and you can see that in the urine very easily, can't you?
And that's the most direct measurement of kidney injury.
Is proteinuria.
So if I look at your protein, and if it's going up, you're not doing well, and if it's going down, then we're getting better, irrespective of other things.
Okay.
The things that ACE inhibitors and ARBs do for the kidney that's unique is they decrease the filtration pressure within the kidney. Other blood pressure medicines decrease arterial blood pressure throughout the body, but not within the kidney. And that's good and it's bad.
Help me. Explain that.
Okay, well, it's good because if the mechanism of injury to your kidney is too much filtration pressure, like in diabetes, like in people with reduced amount of kidney function, it protects them directly. It's bad because if you're taking your ACE inhibitor and you get food poisoning and you have diarrhea for 3 or 4 days, your kidneys will shut down. They can't preserve their blood flow. There's a backup mechanism that the body has to preserve blood flow to several vascular beds, including the brain, which is kind of good, and the kidneys, showing the 2 most important part of the bodies.
Right,
I
of
didn't
course.
say the heart, but anyway, we see people all the time who take their ACE inhibitors and their ARB while they're getting dehydrated for whatever reason, and their kidneys shut down, which can be dangerous.
So see your doctor and
mainly don't be aware that you're sensitive to hydration. I've seen people have abnormal kidney labs just because they're out in the heat and they get dehydrated from.
Me in the garden. I stay out a little too long, getting lightheaded, sweat it out.
If you're running a marathon or something like that.
Yeah, that's serious stuff.
So, I mean, there's nuances with these medicines. But the same thing that makes it good can also make it bad. So just don't let yourself get dehydrated, and you'll be great with those medicines.
On ACEs and ARBs.
Myself. Now, the final category, the third category of medicines are calcium channel blockers. Now, there's several different kinds of calcium channel blockers, but what I talk about for blood pressure are the ones called the dihydropyridine calcium channel blockers.
Is there a common name for that?
Nifedipine, amlodipine, Nicard. There's several other ones, but those are the main 2. And those are the most effective at dilating small blood vessels and lowering your blood pressure that way.
So it's easy. The blood's easier because where the blood vessels constrict down in the arterioles and these what are called tissue beds or something like that. That's where most of the resistance is.
That is, and you reduce that resistance.
And then the blood goes through more easily, less load, less blood pressure. Very interesting.
Now you have to be aware of your side effect profiles of all your medicines. And I'll tell you my belief, which since I believe it, I think it's true.
I want you're here, Kellar, because I want your opinion. I trust your opinion.
I think, in general, with blood pressure medicines, the benefits of the blood pressure medicines reside at the lower dosage range, and the toxicity resides at the upper dosage range.
That makes a lot of sense.
For instance, when I was a young doctor, we would start people on 50 milligrams of hydrochlorothiazide, and we would go to 200 milligrams of hydrochlorothiazide to treat their blood pressure.
Okay.
Now I do 12.5 to 25.
Oh, so it's even effective in the lower range with very little toxicity, but there's still effectiveness. So I guess it goes up like this. Right. It's very steep in the beginning.
The trouble with diuretics is you get gout because it increases uric acid reabsorption, and you get low potassium. In fact, there was a famous study in the late 70s, early 80s called MR-FIT, Multiple Risk Factor Intervention Trial, where they couldn't show any survival benefit in treating high blood pressure. And that was because everybody's potassium was 2.4 because they were on so much hydrochlorothiazide.
So they were already saying that's too low. You need potassium, folks, usually around 4.
But I give you 12.5 or 25 milligrams, you won't.
You won't. So it hides in there, the signal.
And a lot of times I'll see people who are on a very large dose of an ACE inhibitor, for instance, and their pressure is 105 systolic, and I cut it down, and their kidney tests are out of whack. We can talk about kidney tests a little bit later.
Sure, let's do that.
And reduce their dose of the ACE inhibitor, and their blood pressure stays under control. Their kidney tests get better, and they're on less medicine.
I remember when I was in medical school. Now I'm dating myself. I guess this was 84 to 88. So I'm sure I took pharmacology in around 1985. And I remember the lecture where they were saying, there's debate whether you should use little doses of multiple meds and the professor said, now you like to take one drug and really push it to the max before we go to the second. That was the opinion then. Yeah. But what I'm hearing for you, there's less toxicity if you use a little bit of this, a little bit of that.
That was called stepped care, and that was where we were giving people 200 milligrams of hydrochlorothiazide.
Right.
So I get you to 25 milligrams of hydrochlorothiazide and you had a partial response, I might give you an ACE inhibitor to go with that,
On top.
also on a low dose, and get what I want with 2 drugs at low dose instead of toxicity with the higher drugs.
That makes a lot of sense because when as a student, you're going to write on the test what they tell you.
Sure.
But I smelled a rat even back then. I didn't like that.
We know what we know now.
Yeah.
And we didn't know that then.
Sure. Sure.
I don't think you'd get that in pharmacology today necessarily.
Sure, the pendulum swings,
yeah.
and that as we learn more, and hopefully people are open to new data as it occurs.
Yeah.
And it's a human characteristic to hold on to what you know and be very stubborn and dig your heels in.
And you got to keep learning, especially in our biz, don't you?
You do. You really do. And it's not about your ego. It's about helping patients.
Yeah,
and we should stay flexible with that. So the person's gone to their primary care doctor. They've got some diuretic. They've got some calcium channel blocker. They've got an ACE or an ARB, and their blood pressure still isn't getting better. They're having trouble controlling. And those are going to be the patients you see, the tougher ones.
Yeah. First of all, I want to be sure that they're measuring their blood pressure at home. Some people have something called white coat hypertension.
White coat syndrome.
Which is definitely true.
Mm-hmm.
So I really want a better understanding of their blood pressure. I want to know, are they taking their medicine?
Yeah, right. It's called compliance.
Yeah. I try to keep things simple, once a day, twice a day. Almost never more than that unless it's someone with multiple other problems and issues.
I got to tell you something, Kellar. I'm a fairly smart person, but I can't remember to take meds. I'm the worst when it comes to taking something.
I was on an antibiotic 4 times a day, and I had about 6 pills left over when I was at the end of my course.
Yeah, right. Where did that go? Where did I'm terrible at that. So it's not an intelligence
everybody
thing.
Is. And sometimes they're elderly and they need someone to kind of step up and make sure they get their medicines.
All right. So are they taking it?
Yeah. Are there side effects from the medicines that they're having? That's when I identify somebody as a difficult hypertensive, I've split them out into people that really have difficult hypertension and difficult people that have hypertension. Some people just get side effects or think they get side effects with anything.
Yeah.
And they
exactly.
can be hard to convince.
Yeah. I mean, it's kind of stereotypical. You Google all the side effects and you start getting them, and that happens. It happens in medical school too. You take pathology.
I had everything.
And when you're studying kidney that week, everybody gets kidney disease.
I got von Recklinghausen's.
I got von Recklinghausen's disease.
I know it.
So that's just human nature and bias, and we all have fears.
And the other thing is, do they have other problems that we could address with the high blood pressure? Like we mentioned migraines before.
Okay.
If you've got heart failure, you really want an ACE or an ARB as part of the program. I mentioned previously that cardiology and nephrology run into each other a lot.
They really do. You're very complementary.
People who have cluster headaches, calcium channel blockers, vascular headaches can help as well. People can have conditions that make their blood pressure harder to treat. Older people with Parkinson's disease can have something called Shy-Drager syndrome, where they have dysautonomia, the autonomic nervous system. When I stand up, it's extremely complicated what my central nervous system does to regulate my blood pressure.
All these different feedbacks. Yeah.
Well, if you've got Parkinson's, you just don't do that too well. And I can really hurt you with blood pressure medicine. In other words, you stand up, you black out, you fall down, break your hip, hit your head.
Right.
I can't tell you how many times a fall is an entry to a life-changing, and not in a good way, series of events for an older person.
Oh, man, yeah, broken hip and mortality is high.
I have some people that they'll be sitting and they're 140 over 100. They stand, they're 90 systolic.
So that's very low.
How do you treat that?
Ooh.
Well, I'll tell you how you treat that.
Please.
First of all, you mostly worry about the low blood pressure. That's the most dangerous to them in the short run.
Okay.
Secondly, you want to give something like a calcium channel blocker in a low dose at bedtime because they're going to be lying down and their pressure is going to be higher at night.
Okay.
And you tell the family doctor, check their pressure standing and don't crank anything up unless we talk or the pressure is really changing, because they're much more at risk of being harmed with blood pressure medicine. Those can be among the most difficult high blood pressure patients to treat.
So not a toxic side effect, but a physiologic side effect with huge consequences.
Yeah. Well, and it's just a secondary disease process that has a big impact on your choice of therapy. And we try not to do harm, and that's not always easy.
That's tough. And I know in hospitals they try to make falls never events, like it should never happen. Well,
I can be standing right next to you, and if you fall, you're going to hit the ground probably.
Yep. You can't even get there in time. Yeah. So they like to call them never events, but in reality, they should be rare events.
Yeah.
And you can just do your best.
Yeah. But at least not make it worse with your blood pressure medicine.
Right. Right. So somebody's got some really bad blood pressure and their kidneys have started to fail. You mentioned that there's a very simple test. You can just look at the protein in the urine. That's with a dipstick. You pee in the cup, you take the stick, you put it in. Got these little squares. They change colors.
Yeah. Actually, we do a little more precise test with that. We used to do 24-hour urines, which is kind of a nuisance.
It's kind of a nuisance. And let me explain that. You have a jug. Yeah. You carry it around with you.
This is my little yellow friend.
My little yellow friend. And somehow you have to bring it and pee in it all day and collect it all. And it's a hot summer day and it's disgusting. And then not a fun test.
But we figured out a hack for that.
Oh, tell me the hack.
We can do a urine protein creatinine ratio because we know that. Let me back up and talk about creatinine for a second.
Please.
Creatinine does not cause kidney failure. It's not toxic, but it's easy to measure, and it comes from our muscles. So every day our muscles do their job, and they put a little bit of creatinine in our bloodstream, and the kidneys filter it out. And normal creatinine is 1, kind of a convenient number.
That's nice. I can remember that one.
End-stage renal disease would be a creatinine in roughly 8, 9, 10.
8. Oh, so it's way up. It's not just a little. You're not shaving hairs here. It's a big change.
You don't want to see somebody when their creatinine is 7.
Okay.
The horses have left the barn. You know that rural expression.
Yeah.
You want to see somebody whose creatinine is 1.8 or 1.9 or, not
it's early enough.
And figure out what's going on. Now, there are other things that can make your creatinine go up besides kidney failure. But as I mentioned, the protein in the urine, where we measure the protein, and we know about how much creatinine you excrete in 24 hours, which is irrespective of your kidney problems. So we do a protein creatinine ratio.
It's an internal control
estimate about how much your 24-hour urine protein excretion would be. So that's a very sensitive way of looking at either protein or microalbumin as a creatinine ratio. And you just have to pee into a cup and give it to the lab.
Bam. And albumin was the most common protein in our blood.
Yeah, and microalbumin is the first one you start leaking if you have diabetes. It's the canary in the coal mine.
An expression that people in Pennsylvania and Kentucky and West Virginia know, but it's amazing how few people know what that means.
I'm from St. Louis. I was never in the coal mine, but
you knew.
Yeah. Oh, yeah.
Essentially, the canary in the coal mine is the early warning system, an old biologic warning system. In the mines, if there were poison gases, the bird would take it first.
Yeah. So, getting back to what the creatinine in the bloodstream is, what I'm usually sent patients for. Your doctor gets your blood, and your creatinine is 1.5, and so the lab calculates a GFR, which is sort of one size fits none.
Glomerular filtration rate. That's telling us how are these little balls of cells filtering your blood.
Exactly.
And higher is better.
Yes.
Yes.
Yeah. Well, your GFR is down. You got to go see Dr. Winkelmeyer.
That's it. Call Kellar.
And it may be that you're taking your ACE inhibitor like you're supposed to, and you've been having some arthritis, so you're taking meloxicam or ibuprofen.
What does that do?
Well, the ACE inhibitor affects the outflow from the glomerulus, and the anti-inflammatory, like ibuprofen, affects the inflow. So together, they reduce blood flow in the glomeruli dramatically. So they make your creatinine go up. They won't cause protein in your urine. So if I see you and your GFR is down a little bit and you don't have any protein in your urine and you're taking a whole bunch of ACE inhibitor and meloxicam or another NSAID, I say, well, you don't have kidney disease, but you will if you keep this up because...
And it's reversible at that point. It's reversible.
If you can get off the arthritis pill.
Okay, find something else maybe.
Or I had an older farmer who was just stove up with arthritis, and we opted just to stop his ACE inhibitor because we used something else for his blood pressure, and his creatinine came back down. And
Gotcha.
'cause I don't have anything nearly as good as those arthritis pills. I have that talk with people a lot who have serious arthritis and have kidney disease, and it's you don't want to go down the OxyContin trail. And we have Tylenol arthritis, which is Tylenol. It just says it's for arthritis. And it's a painkiller, but not an anti-inflammatory.
Right, right. In fact, for years, they didn't even know how it worked.
No.
Looks like it goes through cannabinoid receptors is the last I heard.
Yeah.
Isn't that interesting?
And IV Tylenol is super effective and super expensive.
Yeah, it's very expensive. Well, they got to pay for the lunches and the advertising. Yeah.
At any rate.
It's come down, but
I'm meandering far afield. But that's just an example of sometimes when your serum creatinine would be misleading as far as kidney disease. But the urine protein excretion is true. If it ain't right if you got protein in your urine.
So you see somebody, their protein to creatinine is high, their glomeruli are getting damaged and whatnot. Boy, that's getting serious.
Well, then you want to reduce the flow in the glomeruli. So if you can, you use an ACE inhibitor or an angiotensin receptor blocker.
Okay.
You control their blood pressure really well. If they're diabetic, get that hemoglobin A1C down below 7.
All right, let's talk about that. Your average blood, and you'll see hemoglobin A1C talked about on TV ads now because there's all these ads for weight loss injections.
I remember when
drugs.
It came out, and we used to say under 9 was good.
Under 9, yeah. So when your blood sugars are high, these sugar, they're called moieties, they're essentially sugar molecules, start sticking on your blood, and they start sticking on your hemoglobin. And if it's going up, it gives you some idea of the average blood sugar for the past few months, right?
Well, red cell's life expectancy is 3 months, so it'll give you a 3-month average of blood sugar. It's ingenious.
It's ingenious. In fact, I have
another number for me to look at, too, with my patients.
Yeah, and in my world, they used to say, hey, do these glucose tolerance tests. It took 3 hours and half a day out of work.
Yeah.
I just get a hemoglobin A1C. It gives me 90% of what I need to know. So it tells you if you have high sugars. So high sugars from diabetes, either you're type 1 and you stopped making insulin, that's a whole nother world, or you're type 2 and you're just living on these carbohydrates, you've become overweight, you have metabolic syndrome.
It is a brave new world for type 2 diabetes these days.
Yes.
I saw somebody the other day who lost 100 pounds on one of the GLP-1s.
On the GLP-1s,
100 pounds.
It's as good. It's almost as good as stomach bypass.
I mean, that's a life-changing weight loss. It took him a year and a half, but...
Oh, yeah, it's not going to happen overnight, but it's very dependable.
Yeah.
Now, we
wish they weren't so expensive.
They're frightfully expensive, and we've talked about this before, is substituting one addiction for another, because a lot of these people, the word on the street is people gain the weight back when they stop taking the injections.
That's true.
That really shouldn't happen if you've done a lifestyle change, but it's a lot quicker to give the shot and move on to your next patient and not do what you have to do. But but getting the blood sugar down, getting the weight down, certainly important, and certainly as an initial therapy. And like I see women who are trying to get pregnant and stay pregnant, and they're running out of time.
Yeah.
They're in their 30s, getting near 40, and they've got very little time. We got to get the weight off, and I'm very grateful for the GLP-1s.
Oh, yeah. And they keep discovering beneficial side effects from them, like they're beneficial for chronic kidney disease.
Really?
They're beneficial for cardiac function. And they may have a beneficial effect for Alzheimer's disease as well.
For Alzheimer's, I'll be darned.
They're going to be adding it to the water.
Yeah, like the cardiologist wanted to put statins in the water. Now the endocrinologist want to put GLP-1s in the water.
Well,
interesting.
Cardiologist coming up with the poly pill for the third world, a pill that's got statin, blood pressure medicine, everything kind of in a single
kind of in
pill.
one, better than nothing on a public policy
for a population that's underserved. So
interesting.
I hate to wander too far afield from
I like it. I want to talk about fun stuff here. Yeah. So somebody's had diabetes, this high blood sugar has been damaging their kidneys. Mm-hmm. How do you know when it's too late? When do you have to start going on dialysis or consider a kidney transplant?
Well, that's a whole different topic.
That's a whole life.
It's not determined by a number. It's sort of the gestalt of the person's condition. Are they sick? There's two kinds of side effects or symptoms that you get as you get advanced kidney failure. One is you fill up with fluid and can't breathe, and that's pretty easy. The other is you get something called uremia, where the toxins build up in your system, and it's kind of like the example I use is boiling a frog. If you throw a frog in a pot of boiling water, they jump out. But if you put them in tepid water and heat it up to boiling, they stay in.
Is this true? I've heard this for years.
I've never tried it.
I was like an urban myth, right?
Well, yeah, it's probably.
I wonder if that's true.
Probably a country myth. They don't have any frogs.
It makes a lot of sense, however, when you slowly change things.
Well, people always tell me they don't feel that bad and they look terrible.
Yeah.
When you start losing muscle mass. And then you have the conversation, and the conversation kind of goes like this, I think we need to talk about dialysis. Well, I don't want dialysis, doctor.
Yeah, right, yeah.
I said, I didn't ask you if you want dialysis. Nobody wants dialysis.
Right.
The question is, are you willing to take dialysis, or would you rather just have it managed without dialysis and die of kidney failure?
Right.
And I said, what I don't want to have happen, which happens all too often, is someone won't do anything until they're almost dead, and then they want everything done. And it's very hard to bring somebody back from the jaws of death to any kind of shape.
Yeah.
You have to own the problem and say, okay, these are my options. This is what I'm going to do, and I'm going to do a good job of it. And you're going to help me, and we're going to do it together. And the patient to make the choice between the various modalities of renal replacement, including transplant.
Comes down to acceptance.
Yeah.
Can you finally make your way to acceptance after you've stopped bargaining and denying and all that kind of stuff? This is true for everybody. Some of us are better than others, maybe.
But I take care of people on dialysis, but mostly I keep people off of dialysis by treating their blood pressure and their other risk factors for progressing. And I've had people with chronic kidney disease that I followed for 25 years who are still not on dialysis.
And you were able to avoid it?
Well, they pretty much took care of themselves and do what they say. I've seen people who've had diabetes for 35 years and don't have any kidney disease or side effects. But they have been on their diabetes like stink, seriously taking care of themselves.
Like white on cauliflower.
That's right.
I tell my patients, the only white thing that's good for you is cauliflower, usually.
My daughter made a cheesecake out of cauliflower once, and it was okay, but it wasn't cheesecake.
No. And when you make spaghetti on a spaghetti squash, you got your pile of spaghetti squash, you put on your meatballs, your tomato. You just don't say it's not going to taste like spaghetti. It tastes like...
You got to adjust your...
Right. You change your expectations, but it's still good.
It was fine, but I kind of wanted cheesecake. But
anyway. Yeah. Boy, so this can get really, really complicated. It runs in. Let's delve into a little bit. This is very controversial. It seems that African Americans have higher rates of high blood pressure than Africans in Africa. And there's been this hypothesis that American blacks are more sensitive to salt because it was a survival benefit in the passage in the difficult passage from Africa to.
I've heard it speculated as a genetic adaptation to places with malaria.
Interesting. So you don't have any particular insights or new thoughts. I've been reading about this, and it's very controversial. Anything about race, obviously, is a hot button topic. It's hard to talk about anyway. It's loaded.
My treatment is individualized. I know you kind of drift that from the way I treat high blood pressure.
You don't want to treat everybody the same.
No.
And just so because African Americans have a higher rate of blood pressure problems doesn't mean you treat them all the same like anybody else.
No. I use generally the same medicines and have the same benefits or lack of benefits.
Right. Yeah, so boy, this is a huge topic, Kellar. Are there any things that you would like our audience to consider as we begin to wrap up this conversation? Is there anything about blood pressure that are things that are misunderstood, or any general policies? Is there anything you would like to leave our folks with as far as recommendations?
Okay. Well, for one thing, find out if you have high blood pressure or not.
Okay.
Many people running around with hypertension have no idea that they've got it. So you won't know it unless you get your blood pressure checked.
So, and they even have health fairs. You don't even have to go to a doctor necessarily. Sometimes they go around in a mobile unit, or you can go to a pharmacy. So I see in the supermarkets, you can put your arm in the machine, get your blood pressure checked.
You can buy a blood pressure cuff for $40, $50.
All right, so not expensive.
And if you've got high blood pressure, it's extremely helpful to have home blood pressure readings. And you want one that goes on the upper arm, not on the finger.
On the finger. Oh, okay. So the upper arms, and it has to be the right size, right?
Correct.
If you've got big arms for whatever reason, you need a big cuff.
The other thing is, I say that treating hypertension is a relationship. It's not a one-off. I don't see you once, put you on something, and then tell you to come back in 2 years. I mean, I see you as often as it takes to figure out, well, we try this. Is that right? Is it too much? Is it not enough? We try this. We look at your labs.
Expect it's going to be a process.
Yeah. And as time goes by, you might get older. Something might change. You could lose weight. You could gain weight. You might develop other problems that could be impacted.
Right. So it's going to be a dynamic, moving target.
Yeah. And that's the way doctoring should be, I think.
Well, Kellar, it's obviously a big problem. Obviously, everyone is different. How you manage this problem that has enormous ramifications for overall health is individual. It should be individualized. And a theme I come to episode after episode is that finding an expert who really has done this for a while and really understands the subtleties and the ins and outs of your condition is just priceless.
Well, as I said, this is a great time to be taking care of hypertension because we have a lot of options and a lot of inexpensive options compared to other conditions.
That's wonderful. So get it checked. Go see your primary care doctor. If it's tough, see a nephrologist like you if they can find one. And certainly don't let it go unrecognized. Treat it and potentially avoid a whole raft of health problems down the line.
And realize that when you treat it, you have to go on. I mean, you're not cured of it. We're treating the symptom of hypertension. We're not curing the underlying cause, unless you've got one of those secondary causes.
Right.
So don't forget about it and get off your medicines and go back to, denial, which is not just a river in Egypt.
It's not just a river in Egypt, right? And I guess I'll come back. I'll circle back around this primary or essential hypertension, if it's due to inflammation of your blood vessels, due to poor diet, due to being overweight and whatnot. Certainly keep an eye on those things. See if you do what you can to improve those factors, and you might not ever need to go on medicines if you catch it early.
That's right. Yeah, exactly.
Fantastic. Well, Kellar, I've learned so much from you. It's really wonderful having you in the community. I'm so glad we have an expert like you to rely upon and turn to in these tough cases. And once again, thank you very much for your time today.
Okay, thanks, Gil. Always nice to see you.